Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps.
For sure. And isn't that, as you go around each booth, you could almost booth to booth think of an example of how our thought process around age-old problems is pretty easily influenced. Just maybe I should just speak for myself, but I know I am, maybe too easily, but, just talking to really smart, knowledgeable educators and kind of understanding the way they classify or think about a problem and how they've changed their incision approach or their fixation technique to account for that is so powerful.
Yeah. Well, speaking of like new approaches, I mean, is there anything that's had more changes than the insertional Achilles? It's crazy to think. I feel like that's been a fairly, other than the approaches that were used for it. I had a mentor, Stan James, who took care of a lot of athletes when I was in Eugene, and he was with track and field, and he would talk about his insertional algorithms and treatment and how he would manage them. And he would kind of, as a proponent of basically dual incisions, medial, posterolateral, take a big cutout. And he's like, I wouldn't fix it with anything, and obviously they keep him in a cast for a long time. And he's like, they did fine, And now we're going down to not touching the tendon at all or the insertion at all with the Zadig. Yeah, I know. Or now you're really getting after, but you're using like an MIS approach, the insertional MIS speed bridge that Arthrex came out with, and I'll even use a scope with that, which really makes everybody nauseated for more reasons than that. But just the innovation that's occurred, I think, has been really cool to see. Because it is a problem when the wounds break down. That's a problem. I do think there is some shoe wear difficulties if you look at some of the even like with the central splitting approach, which is great. Like it's a great workhorse incision, but there are some patients that I still think have some incision difficulties with shoe wear, and so I've really appreciated the different approaches. And I think it's funny to see now only this like divide. It's almost like a political divide that's happening between you still attacking it at the tendon versus, completely ignoring it. And, at the end of the day, it'll probably be about same outcomes, but it's, I definitely think I'm still in the insertional, like addressing the pathology, taking down the Haglunds, repairing the tendon. That's kind of where the camp that I lie in, I think, and, for whatever reason, but there's definitely different ways to look at it.
Isn't it interesting though, Nick, to your point, like, with that divide, maybe, starts to come some research and maybe, our understanding really starts to develop from where I think was always like a ground zero, really ignorance, like what causes the pain, and to think about the success that a procedure like closing wedge osteotomy Zadig can have for many patients. And the research around that in terms of how we're physically or biomechanically changing the tension, et cetera, starts to help us understand, at least for some patients, for some segment of patient population, where the pain is coming from or where it's not coming from. So, yeah, I mean, we continue to learn about these age-old pathologies, and we've all been trained, how to treat it or fix it, and we know what we know, but we don't know what we don't know, and I think that's where industry, and evolution of technique and implant, helps us to maybe expand our boundaries a little bit. And then to think about how the two camps that you mentioned, there's maybe a don't attack the tendon, attack the morphology of the calcaneus. But doesn't it seem, though, that then the other camp, if you will use that paradigm, rolls out with a more minimal approach to posterior decompression, right? I haven't personally been to that training table yet, but I'm really interested in learning how to do central splitting and decompression and fixation through a smaller window. That sounds like progress to me. That's an evolution. Yeah. And then we have to figure out, the decision modeling around who gets what, right? Yeah. When do we do each technique? And, yeah, I wish I had that answer. Again, there's so much to learn, and that's always really exciting to me.
Yeah, most definitely. Well, speaking of soft tissue, it feels a little bit. I feel a little bit. I don't know if sad is the right word, but it's going to feel a little weird having Artelon part of Stryker. What a big acquisition that happened, and now So now, obviously, you think about lateral, like ligament instability. Maybe we'll just call it that. But now you have Stryker / Artelon is on one front. You have ConMed and the BioBrace looking at it. Arthrex with the OG internal brace has been around. And then even Smith & Nephew has the Ultra Brace. And so interesting to see. And I'm sure there's others that I'm missing, but all the different fixation options you're seeing for some of the lateral ligamentous instability with augmentation and what sort of options that we now have. Whereas before it was, a perineal sacrificing non-anatomic reconstruction or allograft or autograft kind of reconstruction, weaving it through the fibula, that works great, but it's just interesting to see all the different options that have been coming down the pipe.
Yeah, and with options come algorithms, right? It's certainly a lot of work to do. I think that decision-making algorithm always trails and hopefully, can be somewhat data-driven, but always anecdotal, right? It's just fascinating to see the interplay between having a collagen allograft, soft tissue allograft, and weaving in absorbable microfibers to give you time zero strength and still maintain tissue elasticity properties. Mind-blowing, right? When all you had before was cadaveric or as you said, non-anatomic or artificial suture, it gives us more
fiber wire.
Okay, I wasn't going to say it, but and again, that I think that has a role. I wouldn't,
for sure.
Wouldn't downplay that. We don't know, really where the future of these kind of biopolymer collagen allografts lies. But with more tools in your bag, you start to kind of find scenarios where you're like, I think I understand this now. This is where I'm going to use blank product. And I've really enjoyed the kind of counterculture narrative around Artelon and share your sadness to see it consumed or assumed by popular culture. But I think that's telling, right? I think, again, that kind of speaks to the market. And I think people recognize that this option is probably here to stay.
Yeah.
I'll say that softly.
Yeah. Well, I think, I made the comment about fiber wire, but you think about like the fiber wire and the metal fixation screws that came out years ago, where would we be without that kind of innovation? And how much of what we are seeing in the exhibitor hall stems from that, and especially giving us so many more soft tissue options. And so it's just amazing to see how some of these things that started, like where they started, and it wasn't that long ago that all this stuff started. And
the origin story around this development is always a fascinating backstory, right?
Absolutely incredible. Well, okay, so now maybe a little bit of a hot topic. Where are we going to go with MTP joint arthroplasty? Can you put on you grab your crystal ball and tell me where we're going with that? Is BioPoly here to? I almost said BioPro. Is BioPoly here to stay? It seems like it's caught some steam. Maybe it's catching. It's going to be hard to make up for some bad experiences, I guess, for lack of a better term, with previous implants. But I think that we talked about it before. We think that there's probably a need for some patients that I think are still going to want and need and benefit from a good option for this.
Yeah, I think that the glorious thing about our subspecialty is that it is not a one size fits all problem set that we encounter. The bandwidth is so broad, even within a singular pathology. MTP arthritis, great example. The patient, the young active patient with a central chondral defect and a preserved head morphology without osteophytic change and good motion, but just raw mechanical pain. How do you solve that? We don't have a great option for that. There's been a few that have risen and fallen, and no shortage of interpositional techniques described. And what about the development of unique bioresurfacing options? It really needs to be looked at, right? And yet there's kind of a cultural barrier of entry, a cultural bias maybe, either based on your age and stage in your career, what you've seen anecdotally, what your prized mentor taught you is true, and that's a high bar of entry, I think, for a lot of industry to overcome. Needs to be maybe what we've learned from other resurfacing options that have failed, be it Cartiva or others, or implant loosening, really needs to be looked at critically. I think I don't know, Nick, what do you think? Is that true for every technology that we adopted? Some seem safer than others, be it screw or fixation, but something about joint resurfacing in any joint makes us take pause, I think, because we know that the revision implications for that patient upon failure are just an order of magnitude different, right?
Yeah, I think you think about that, or the total ankle and the journey we've been on there is when they go bad, they go so bad. And
right.
It takes a problem where you had a pretty good option for. It's maybe not like perfect, but it was a pretty good option with a fusion and get them a good, fairly predictable result. And then you put them in a situation where you're like, I'm not sure I can fully salvage this. I mean, it makes it a little bit tough to stomach, I think.
But I do think these low-profile implants, like you suggested, open the window of consideration back up a little bit, right? To say, well, that's a pretty small amount of real estate that you're sacrificing to give this patient with these characteristics a resurfacing option.
Well, I think that's where the instrumentation, such as the patient-specific guides. I mean, we talked a little bit about what the future of robotic instrumentation might look like in this setting, and better technology in terms of fixation, initial fixation, polywear, less resection, like you pointed out initially, and then having options for revision too has made a big difference, I think. It'll be fun to see what happens in the total ankle space in the next couple of years, because I get the feeling, and you might even see it here, that there's going to be other stemmed fixation options that are going to be coming out for the revision situation.
Yeah, or a low profile stem for a primary if you're a believer in those mechanics. And I think, any technology is going to be more readily adopted if it comes with the instrumentation and the preoperative planning tools, along with it. I think that's a formula for success. Not only how can we make the fixation stronger or the ingrowth more predictable, but how can we make the procedure more reproducible, technically easier, more readily taught, and how can we lower the learning curve? How can we just help surgeons embrace this, not only for the mechanical benefit that it provides, but for the ease of use. It's really a focus, I think, and you see that in really every space, right? Arthroplasty, MIS, even how to implant biologics, be it kind of collagen graft fixation. It really makes a difference.
Yeah, for sure. So moving off of metal a little bit, I mean, there's software. There's a company called Athelos, which is looking at AI technology. Yeah. That's pretty cool in terms of helping solve some surgeon problems. And I certainly think that may have some role with whether it's scribe, documentation, filling out some of the paperwork, some of the day-to-day, hopefully making things a little more streamlined for us. I think that's worth checking out and seeing how you can apply to your practice, or whatever fields you're in. You might be in the industry and needing to collaborate on some AI projects. That's something to check out, I think.
Yeah, it's so exciting that there's we spend so much time mentally fixated and spinning our wheels around how to mechanically fix problems, but then the day-to-day existence of our week and month and year is really built around mindless box checking and kind of blurb spieling and kind of repetitively doing the tasks that we do, either to keep our private practice alive or to keep our patients flowing, and how much of that can be supplanted or augmented with AI technology is really a game changer, right? Yeah. To spend more of our time talking about fun stuff or innovating a new technique and less time grinding the grind that we do is
or even just getting home 30 minutes earlier for the day, catching dinner is a huge deal.
Yeah, I'm really passionate about the concept of scribing, and it's been around for a while, but to again lower the barrier of entry there and make that more affordable for the system or for the private practice. I think we're right on the cusp of that. Yeah. So that's super exciting. I'll definitely be checking out.
Yeah, for sure. What do you think about some of the soft tissue closure devices and even like suture devices? I mean, and you can kind of think of this a couple different ways. I think we both met Leah Winter last year, and Easy Whip stitch. That's pretty
Yeah,
cool.
so great, so simple. Where they say genius lies in the simplicity, and it's really sometimes simple little tricks that just create that efficiency, or take an age-old problem and just make it 30 seconds quicker. It really adds up, right? To your point earlier.
Yeah, that or the suture guard, and I think there's another one that's out that's similar, but this kind of idea of like getting all the tension off of some of these wounds really helps promote these, whether routine or difficult to heal wounds. I think there's a lot to be said there. I had a patient today, and we don't have that in our system, but that would have been a good application for that problem where I had to wash out a hematoma, and just getting the skin brought back together, I think would have been really benefited from something like that.
Yeah, there's all the mental burn and worry that we have during the procedure itself, but then there's the afterburn, right, of just worried about those things that until now maybe were kind of beyond our control. How can we reduce soft tissue tension and improve local oxygenation? And I think there'd be some great and interesting studies to maybe tap into the real efficacy of those devices. Again, I think with that would come widespread adoption, but really captures your imagination. And again, simple, quote unquote, simple tricks and technologies that lower the burn.
Yeah. Well, and then I also don't want to neglect the imaging crews that are out there. You think about Curve Beam, and we met at an event last year by Simulate weight bearing CT. If you're in the industry, particularly with metal, or any actually soft tissue metal, you should check them out just to know what they're doing and what they're offering, so that if you have your surgeon comes to you with talking about weight bearing CT and some of the things, you understand what they're looking at, what the technology is, because I think there is a lot of collaboration between the imaging, and especially you get into these patient specific situations or algorithms or techniques. That I think is really helpful as well. So I think just understanding what we're talking about when we're talking about the weight-bearing CT scan.
Yeah, do you have access to that in your system, Nick?
No,
right?
I don't. No.
And I think that's the next level, right? Yeah. To have the tool is one thing, but to make it accessible is another. And I love your nod towards Stimulate technology that I think is trying to break down that barrier a little bit.
And then bracing, I know maybe we start to think about that later, but there's a lot of cool bracing stuff out there. DJO is always there, and they always have some really cool things. Taco is a really cool option with just a kind of a new take on almost like the Ritchie brace, but doing it outside the shoe or outside the boot, which is a nice transition piece for some of my patients.
Absolutely, and I haven't worked that into my personal practice, but I'm totally fascinated by that. Again, just from the patient perspective, how often do we see, again, these, we've been doing it the same way for a long time, Nick, right? Like, here's the sandal, here's the boot. Yep. Maybe we can find you a short boot, that's only half as heavy, but still just as
the same.
Yeah. People are like, this is the small boot? This is what you got?
And then the boot that I like a lot has been, I don't know if game changer is a pretty strong term, but like the Vacoped boot. I use that on a lot of my Achilles post-ops. Patients really seem to like them. They can get walking on it really quick. They were there last year. I don't know if they'll be there again this year, but they have some really cool options and some other, technology for things more than just the Achilles. But I think they, if you look at the non-op algorithms or protocols, I guess, out of the UK, they all use that particular boot for a lot of those. And if you follow, I kind of nerd out a little bit on some of the like the Facebook groups, the Achilles recovery Facebook, which I think is very heavy UK, is my sense. But it's just interesting to like read what people are talking about and the types of boots and where they're at in their recovery. And this is a total tangent, but like those are some of the different challenges that patients face on a day-to-day basis. So just kind of seeing the different options that are out there, particularly when you start thinking about, okay, can I put this, if we're going to put, so let's say we're going to do an augmented collateral ligament repair and you want to get them in a boot or in a walking brace right away. Sometimes the challenge isn't like concerned about stability, it's concerned about incision healing. So then you start thinking about different bracing options. And that's where something like the Taco is so interesting to me, because you could potentially have them in a shoe in something that's a little lower profile, not hitting that in skin incision, but it still like protects them almost like a boot would. And I think that's a really intriguing option.
Yeah, I'll just go back to my, comment earlier about how progress is always linked to pain in some way. And so I think, listening to, I really applaud that, taking your ear out to the streets and listening to what the people have to say. Where does this hurt the most? And this is how we can get better, right?
Yeah.
I love that.
Yeah. Well, I am really, really looking forward to seeing you again in person, Tom, and chatting and catching up and checking out some of the booths. And hopefully, this is a little bit of a helpful preview for those who are going. And, we look forward to seeing everybody.
Thanks so much for bringing this to light and for letting me chime in and for leading the way. And I think it's a great initiative. And look forward to seeing you out in the booths and listening to some lectures and learning together. I'm excited.
Can't wait. It'll be a great time.
Great. Thanks, Nick.
Yeah, thank you.